have Pam Woodard with us today. Pam is the head of advanced cardiac imaging at the Mallinckrodt Institute in Radiology. And you know, what we're trying to do here is to bring together clinicians and basic researchers and try to have talks from both perspectives. And Pam is a clinician who does research also, but she's mostly taking care of people. And in fact, I know that her name appeared it was one of the best physicians in the United States and so on in all of those surveys. So she's a very dedicated person who takes care of people. Pam is also on the research end, and the involvement in the profession has been on many different activities in the American Heart Association and the American College of Cardiology, serving on committees, and she published many papers. In terms of her education, she got her MD from Duke University and then continued at Duke with 1 year, I remember, at the Chapel,
my internship.
The rival. I was there 2 weeks ago. They had a basketball game. You didn't want to be there when they had that. So it was a mess. And then she came here for fellowships, for a fellowship, and remained at the Mallinckrodt Institute since. I have to say one important thing is that I really owe Pam a special thank you. And I moved here about 4.5 years ago. We came from Case Western Reserve University. We were really established and had all of our clinical connections. And you know that part of my work has to do with the electrocardiographic imaging work that involves patients in clinical situations. And Pam was the person who really helped us to get started. She gave us an identified space for us at the Chem building, and without her, we would have been lost. So Pam, thank you very much.
Well, thank you very much, Earl. Those are awfully nice things to be saying about me, and I do apologize for the delay sitting in traffic. I'm going to be talking about speaking of delay, yes, I'm going to be talking about delayed contrast enhanced cardiac MRI as a research tool. These are my disclosures. The outline of my talk is going to be on 3 levels. I'm going to talk about what delayed contrast enhanced cardiac MRI is and how you would perform it. Talk about how it's used clinically, and then also give you a little indication of how it can be used in research. We've done some work here with Dr. Rudy, and I'll show a few slides at the very end of how we've correlated with some of the work that he's doing. So what is contrast enhanced cardiac MRI? It's a method of contrast enhanced MRI to look at regions of myocardial fibrosis and cellular permeability. So you're looking at regions of the myocardium which can take up contrast, gadolinium-based contrast agent in a delayed fashion. Initially, it was thought principally to be for myocardial infarction assessment. Judd and Kim, now at Duke University, felt that it would just show scar and demonstrated that it was able to tell you some prognosis about how the patient would do and what type of wall motion recovery you would get after revascularization. So there are several patterns that were demonstrated, and the first is subendocardial. You can see the subendocardial myocardial infarction here. It's actually a very nice demonstration of this, because unless you see this, you really don't realize just how demarcated the subendocardium is from the subepicardium in a vascular way. The subendocardium is the most sensitive to ischemia and also to infarct. So when you have a myocardial infarction, that's the first to go. And when you have a subendocardial myocardial infarction, you have this normal myocardium distal to that, and it's that myocardium that will allow the function to recover should you go ahead and revascularize the patient. On the other hand, there are patients who have transmural enhancement, and these are patients who have a full thickness myocardial infarction where the damage is far greater. It's extended from the subendocardium all the way through the subepicardium. And in these patients, revascularization is unlikely to help the wall motion recover. So surgeons, for instance, in particular, are interested in whether or not a patient has a subendocardial versus a transmural myocardial infarction, because what they're interested in doing, if they want to take a patient to the operating room, they'd like to have some benefit for the surgery that they're doing. In other words, they would like to know that their benefit versus risk ratio is relatively high. So if they have a patient especially who has is a poor surgical risk, they will often ask you to go ahead and do this type of research or type of study in order to demonstrate what type of outcomes the patient will have. Now, there's a third type of enhancement pattern in patients who have a myocardial infarction, and this is a pattern demonstrating microvascular obstruction. So what you see here is a very large transmural myocardial infarction, and you see in the center of it this area of black. And this area of black is a region of myocardium, which on delayed enhancement, the contrast is not getting into. And the reason why it's not getting into it is because the microvascular there is obstructed by platelets and debris. If you waited for a very long period of time, and this is in a patient who has an acute myocardial infarction, you might eventually see enhancement. However, this is a very poor prognostic sign, and patients who have microvascular obstruction usually don't do well. Now, how do we perform it? It's actually a fairly simple type of examination to perform as far as contrast-enhanced studies go. When you perform delayed cardiac MR, you'll be injecting double-dose gadolinium, usually. It's about 40 mils. You can inject at any rate, so you don't require a power injector. You then wait 10 minutes, and you then select an inversion recovery time to null the myocardium, the normal myocardium. You want the normal myocardium to be black, and this inversion recovery time is between 200 and 300 milliseconds, but it can vary. And so some companies have provided a cine sequence that has a different inversion recovery time at each frame of the cine. So you can run this, and you can check to see at which frame the myocardium, the normal myocardium, is the blackest. And if you were running this on a scanner, numbers would actually come up down here that would indicate which would match up to each frame and indicate where you would set your inversion recovery time. So you might run one of these just prior to it, and then you would go ahead, set your inversion recovery time, again, somewhere between 200 and 300 milliseconds, and then use a two-dimensional gradient recalled echo sequence. Turbo Flash is actually the trade name for one of the scanners. Gradient recalled echo sequence, the T1 weighted sequence. Set the inversion recovery time, and then obtain your images. And we usually obtain a 4-chamber long axis image, 2-chamber long axis image, and a stack of short axis images. Now, and I'll show you some of those in a minute. So people have asked, what are the possible mechanisms behind delayed contrast enhanced imaging? People have asked, does it happen, when I give this talk to clinicians, they ask, does it happen in acute and chronic infarctions? And the answer is yes. In patients who have acute myocardial infarction, the thought is that the myocytes, the membranes, become ruptured, and then the contrast agent can passively diffuse into the intracellular space and get trapped in there, and then it takes a while for it to get out in comparison to the normal myocardium. For chronic myocardial infarction, the thought is that the expanded interstitial matrix, the scar, traps the gadolinium-based molecules. So these are some cartoons that show this. This is from a book by Charlie Higgins, but it's a nice example. These are the normal myocytes. You can see the gadolinium in the interstitium gets into the interstitium, then gets washed out. Whereas in a patient who has acute myocardial infarction, you have cells where the gadolinium gets trapped in the leaky myocytes, and takes a while for it to clear out. So it clears out in a delayed fashion. So you still have contrast enhancement in the myocardial infarction, while the remainder of the myocardium is black. For scar tissue, the thought is the expanded interstitial matrix traps the gadolinium molecules, and the gadolinium then washes out in a delayed fashion as well. The time to wash out is very similar for both acute and chronic myocardial infarction. Usually, the peak enhancement is on the order of 10 minutes, but then to wash out, 20-25 or 30 minutes. So we talked about infarct assessment and why it's important to differentiate between transmural and subendocardial myocardial infarction. But you can use delayed contrast enhanced imaging for other pathologies as well. Essentially anything that causes leaky myocytes or fibrosis within the myocardium. In patients who have dilated cardiomyopathy, you get a striated type of pattern. In patients with hypertrophic cardiomyopathy, you see the thick myocardium, the thick septum, and then patchy areas of enhancement in regions of fibrosis. And in patients with amyloid deposition and in the fibrotic endocardium, you see areas of enhancement as well. Patients who have myocarditis have permeable myocytes because of the inflammation, and you get this subepicardial enhancement, which then later clears. So these are just some of the examples. So this is just to show you an example of how this is used clinically. Usually these images are obtained. The delayed contrast enhanced image is over here on your right. It's usually obtained with cine sequences that you see over here. So this cine sequence is it's a balanced gradient recalled echo sequence. For Siemens, this would be called a true FISP. For G, a Fiesta. But the cine sequence shows you that there's an area of decreased wall motion abnormality in the region of subendocardial myocardial infarction, small area of transmural myocardial infarction. So you have a hypokinetic posterior septal wall, and the area of subendocardial enhancement, that region would be expected to improve, the wall motion would be expected to improve with revascularization. Now here's a patient who has a transmural myocardial infarction, and you can see that there's excessive wall thinning. It's an akinetic posterolateral wall. And you can see the corresponding enhanced region on the delayed contrast enhanced imaging. And this is a region that would not recover with revascularization. Another patient, this was a patient who Mark Moon had sent us because he wanted to perform the door procedure, which is an aneurysmectomy. In other words, removing this area of thinned myocardium to try to improve the left ventricular ejection fraction, the contractility of the left ventricle. When we did the delayed contrast enhanced imaging, you could see that this entire area is scarred. It's actually the same signal almost as the blood pool. And his thought was, after seeing these images, that he probably wouldn't perform the procedure principally because if he removed the aneurysm, the patient wouldn't have much left ventricle available afterwards. So he decided not to perform the procedure. Now, delayed contrast enhanced MRI can also be used with perfusion imaging to differentiate between myocardial infarction and ischemia. And when you perform myocardial perfusion imaging, in order to determine whether or not the patient has ischemia, you're going to need to inject your contrast in a dynamic fashion. So the same contrast that you use for the delayed enhancement, instead of just administering it and looking at it in a delayed fashion, you're going to start out by watching the contrast go in a dynamic fashion. So you'll inject the contrast very quickly using a power injector, and you're going to inject it at about 5 mils per second because you want a tight bolus. You'd like to be able to see it wash into the myocardium, first wash into the blood pool, then wash into the myocardium, and wash out. And during this time when it's washing into the myocardium, the area that is hypoperfused will be the area of myocardial infarction, or if you administer it during adenosine, which is a vasodilator, and simulates ischemia, you'll be able to see areas of ischemia as well. So this is how we would perform an adenosine study. We would go ahead and run our adenosine intravenously at 140 micrograms per kilogram per minute for 3 minutes. And this is the same way that you would perform your run your adenosine if you were performing a SPEC study. You're then going to give some of the contrast, a smaller amount, 10 mils, run it intravenously very quickly, as I mentioned, and run a very high temporal resolution gradient recalled echo sequence so that you can see the contrast wash in and wash out. And you get about 3 to 5 slices covering the R-to-R interval. And you perform this over 60 to 70 heartbeats, so you have to realize that this breath hold, the patient isn't going to be able to perform the breath hold for 60 to 70 heartbeats, which is about a minute. They're going to only be able to hold it for about 20 seconds. So we usually ask them to go ahead and hold their breath initially, and then go ahead and gradually release it. At the completion of this, we then can add a second injection of the contrast to bring the total dose up to double dose to perform the delayed contrast enhanced imaging to assess for viability. So this is a cartoon of how the contrast enhancement works. If you have normal myocardium, during adenosine administration, the contrast is going to wash in and then wash out. If you have infarcted myocardium, it's going to give you hypoperfusion in the region of the myocardial infarction initially during the adenosine administration. But then as time goes on, the contrast is going to wash in a delayed fashion and then wash out in a delayed fashion. As far as ischemic myocardium, you'll get an area of hypoperfusion as well during adenosine administration. So if you just were looking at your adenosine, the perfusion during adenosine administration, you wouldn't be able to tell what was infarct or ischemia. So it's going to be very important to look at your delayed contrast enhanced imaging to determine what area is infarcted and what area is ischemic. So these are some examples of what this looks like. When you have an adenosine stress image, you can see here on this particular patient, there's an area of hypoperfusion in the inferior wall. When we went ahead and performed the delayed contrast enhanced imaging, you can see that there is delayed contrast enhancement in the subendocardium, small area of transmural enhancement, and that region of myocardial infarction matches almost perfectly with the region of hypoperfusion obtained during adenosine stress imaging. This area, this region of hypoperfusion, is then secondary to a myocardial infarction. Now in this patient, we went ahead and performed adenosine stress perfusion imaging, and you can see that there's an area of hypoperfusion here in the interseptal wall. But if you look at the delayed contrast enhanced imaging, there isn't that enhancement there. Maybe there's a little tiny bit of subendocardial enhancement. However, you can see that the area of hypoperfusion is far larger than the area of delayed contrast enhancement. And the territory in this patient here is predominantly ischemic rather than myocardial infarction. Now, clinically, there are some things that you would have to know, and if you were performing this for research, you would quite likely have an MD with you, so that you would go ahead and make sure the patient has 2 IV lines. When I tell clinicians about this study, you want one for the contrast and one for the adenosine, because the adenosine remains in the line, and if you push your contrast in very quickly behind it, you actually are giving a bolus of the adenosine rather than slow infusion, and you can get heart block. Now, I should point out that the adenosine is very short-acting. So it's a good drug to use for research, because if the patient becomes symptomatic, you can just stop the adenosine, and the symptoms, especially heart block, will recover. However, it's usually still considered poor form to go ahead and put your patient into heart block. So. Now, I can talk a little bit about some non-ischemic indications. I think I showed you a few on my composite slide earlier. But here's a patient who was a young man who had chest pain. And he came to us because the cardiologist thought that he might have an anomalous coronary artery that was getting compressed during exercise. He had a troponin leak. He had elevated troponins, serum troponins, indicating that there was some sort of myocardial damage. And he didn't have an anomalous coronary artery, so we went ahead and performed delayed contrast enhanced imaging just to see what we saw, especially because of his serologic, the elevated troponins. And you can see that there was extensive subepicardial enhancement. So you know that this is an ischemia because the region of the myocardium that's most sensitive to ischemia is the subendocardium, and it has to be something else. So we talked to him, and he had had flu-like symptoms 1 week prior, and his viral titers later on that were drawn were positive for Coxsackie. So this subepicardial enhancement, one of the things that it can be is a myocarditis. It can be seen in other collagen vascular diseases. It can be seen in sarcoid. However, in a young person, somebody who's 15, 16 years of age, the most common cause of subepicardial enhancement is myocarditis, and usually a viral myocarditis. It's another patient who had chest pain and a history of recent mononucleosis. And you can see that there's delayed subepicardial enhancement here in the intralateral wall. So some of the pediatricians, the pediatric cardiologists, will follow these patients to try to demonstrate clearing. I guess one of the concerns recently has been with, I know that there's a patient at Children's who did not, the enhancement didn't recover. And one of the concerns was, could they go ahead and let this child go ahead and play sports? Because one of the concerns was, would this serve as an arrhythmogenic focus? In other words, would there be a penumbra that, and the child might end up having some sort of arrhythmia while playing basketball or performing strenuous exercise. So this particular patient returned 2 weeks later for a repeat cardiac MRI, and the delayed enhancement was gone. That's usually the case. It's usually that the foci, there may be some tiny scar that is below the level of visualization. Occasionally you'll have a large area of scar that will remain and will be visible, as I mentioned, and usually this causes much consternation among the cardiologists who are watching the patient and trying to provide some prediction as to what the patient can do as far as sports and exercise. This patient was a 16-year-old girl with gradual onset of shortness of breath, and you can see that her function is very, very poor. You can see that she has a very dilated left ventricle, dilated atria, enlarged right ventricle, and delayed contrast enhanced imaging for her demonstrated extensive enhancement. And you can see not only subepicardial enhancement, but also that striated appearance in the septum. And the striated appearance can be seen in patients who have chronic dilated cardiomyopathies. But one thought in her was that because of the subepicardial enhancement, that the etiology originally may have been viral, that she had started out with a viral cardiomyopathy, developed a viral myocarditis, developed a dilated cardiomyopathy, which then became chronic. Hypertrophic obstructive cardiomyopathy also shows delayed enhancement, usually in the septum, which is thickened. There's fibrous deposition and collagen, which can be found in this region. You can also see areas of myocardial disarray. It's a congenital problem. However, it's not the myocardial disarray that is associated to the delayed enhancement. It's the collagen and the fibrosis in the thickened septum that enhances in a delayed fashion. Also, patients who have amyloid deposition. These patients, it's very interesting because it's been shown that not only do you get delayed enhancement, principally in the subendocardium, the blood pool, if you notice the blood pool in comparison to most patients, these are frames from a cine image, and these are delayed contrast enhanced images below. You notice the blood pool is dark. In most patients that I've shown you so far, the blood pool is bright, and the thought is that that correlates with amyloid deposition throughout the body elsewhere. So the gadolinium is taken up in a delayed fashion, and therefore when you image it 10 minutes, or taken up rapidly, I should say more rapidly than the other types of fibrosis, because there's amyloid deposition throughout the body, you end up with a dark blood pool at the 10-minute point of imaging. So this is another patient, same etiology, amyloid, cardiac amyloid. So 54-year-old man, he had new onset of heart failure and a history of multiple myeloma. And amyloid deposition is often seen in patients who have multiple myeloma. You can see on the cine imaging, this is the short axis image, but delayed contrast enhanced imaging all through the endocardium. And just to point out how the blood pool is dark in comparison to the blood pool in most patients, a patient who had a myocardial infarction. So with the contrast being taken up in the amyloid deposition throughout the body. Now this particular patient we know had a lot of amyloid deposition. I want to point out just on the scout images you were able to see lesions throughout the liver. Here's one, here's another. And then also these tiny nodules throughout the lungs were later proven to be amyloid deposition throughout the lungs. Here's another patient. This patient had an eosinophilic cardiomyopathy, elevated eosinophils, which are thought to attack the subendocardium, attack the endocardium, and basically allow platelets to then lay down and form a thrombus. This large dark area here is a thrombus at the left ventricular apex. And these patients have eosinophil-mediated damage of the endocardium, and then the platelets gradually start forming this meniscus in the left ventricular apex. So another thing that delayed contrast enhanced imaging can be useful for is the identification of thrombus versus tumors, with the thrombus being very dark because of the hemosiderin. So you can see this very thin enhancement of fibrous tissue in the endocardium, which then causes this abnormal deposition of thrombus in the left ventricular apex. And this patient was demonstrated to have a peripheral eosinophilia and Loeffler's or eosinophilic cardiomyopathy. So, one question is, how can delayed contrast enhanced MRI be used in research? From what we have done so far, I think it could be used in three ways. One is that it can be used to indicate a reason for abnormal myocardial strain. Essentially, transmurality of the infarct, as it increases, there is increase in abnormality of myocardial strain. And there's some work that we've been doing with Mike Pask that demonstrates that, and he's in the process of writing a grant where we will be using some of his myocardial strain techniques along with delayed contrast enhancement. Because I think that it's not only just indicative of where the infarct is, but I think that it can be used to predict the extent of myocardial remodeling. So that in combination of the myocardial strain can predict the extent of myocardial remodeling and then also patient outcomes after myocardial infarction. And then with URM, providing a visual demonstration of focus of arrhythmia. So I wanted to talk a little bit about one study that we're doing. This is a study that we've been working on with Gautam Singh, who's a pediatric cardiologist at Children's, and Brian Cups and Mike Pask. And Gautam was especially interested in Fontan patients who had Fontan, which is a type of conduit for patients who've had pulmonary right-sided outflow obstruction. These patients need to get blood supply to their pulmonary arteries from their right ventricle, and this Fontan, this conduit, allows those as a repair for this type of abnormality. And the concern was that these children would often have left ventricular failure as time went on. And the one question was, if these children had the right side of their hearts operated on, why would the left side of their hearts end up failing? And what Gautam did was to obtain children who had, and also some adults, young adults, who had had the Fontan procedure, and to go ahead and perform delayed contrast enhanced imaging, and then also to perform tagged imaging in these patients, and then also a look at normal children as well, normal children and adults. The technique he used was the technique that I've described, using the standard sequences for cardiac function, but then also some tag sequences. These are sequences that have lines laid down through the suppression of spins, basically giving tags that can be used then to identify points, which can then be used in a computer algorithm to calculate strain. He then performed delayed contrast enhanced MRI, as I've shown you before, and performed some long axis imaging and then also short axis imaging. So this is what the tagged imaging look like. Let me get the tag imaging out. So this is what our tags, you can see that these are the tags that are laid down on the myocardium. They're essentially a suppression, kind of a myocardial suppression in order to perform those. You can perform those, lay those down in any orientation. You can have them single, or you can have them as a grid as seen previously. So he worked with Mike Pask to go ahead and perform the tag imaging, and then to these cross points, label those as points that could be, you could look at their displacement in systole versus diastole, and then perform strain computer analysis, and then create a nice image that actually describes which have poorer strain versus greater strain. And this actually should be lower to greater. So some of the images, and this actually should be a cine. However, you can see that in this particular individual, there was no delayed contrast enhancement, and the cine image would have shown normal contraction. In this particular patient, there is a focus of transmural scarring, and it's unusual, it's interesting that these children have this because it's indicative that during surgery there is some myocardial damage that's occurring to the left ventricle that's causing a long-term failure or decreased function in the left ventricle. And this area of transmural scarring showed an area of hypokinesis, segmental hypokinesis. This is another patient who had diffuse scarring in the anterior wall, and with the cine images we're working, you'd be able to see an area of hypokinesis in the anterior wall. And so they were able to calculate strain and determine the abnormal strain in those regions as well. And the thought is that they might be able to use that information to provide some indication as to how well these children will do over time, and possibly be able to do something proactively for these patients to prevent the left ventricular failure. And Yoram has just recently given me this slide. This is work done by Yang in his lab, where a patient who has a very large anterior myocardial infarction in this region, this red region, you can see correlates with the ECGI data, where you have a very low voltage, in the region of myocardial infarction, but normal repolarization in areas that are normal. And this can then correlate with the delayed contrast enhanced imaging on MRI to provide a visual depiction of the region of abnormality to correlate with the ECGI data. So, in summary, you can use delayed contrast enhanced imaging to assess myocardial infarction, both acutely and chronically. You can use it to also assess ischemia versus infarct. You can use it to assess non-ischemic myocardial disease, myocarditis, dilated cardiomyopathies, hypertrophic obstructive cardiomyopathy. And then the hope is that it could be used in research to indicate a reason for myocardial strain abnormalities, probably predict left ventricular remodeling, and provide some information that could give you a determination of patient outcomes, and then maybe a way to alter those outcomes. And then lastly, as shown by work that Yoram's been doing, provide a visual demonstration for a source of arrhythmias.
Thank you very much, Pam.
Yeah, any questions?
Is there any problem with using gadolinium because it's kind of isn't it a calcium channel blocker that blocks structure-activated channels and things like that?
There's not a concern about the myocardial effects of gadolinium. However, the big concern recently that the NIH, they had a research study where it was put on hold for a few months, is nephrogenic fibrosing dermopathy. And so the deposition of the gadolinium compounds, the breakdown products in patients who have renal insufficiency. So in most people who have normal renal function, you excrete the gadolinium bound with salt before it starts to break down. However, in these patients who have renal insufficiency and were on dialysis, the gadolinium, the thought is that it would dissociate from the salt and then end up depositing in muscles and in skin. And so we ended up altering the GFR of the patients recruited into our study. We raised it up to 60 GFR as opposed to 30. So basically excluding anybody who had any type of renal insufficiency. Clinically, we give gadolinium to patients who have GFRs as low as 30. However, we usually use single dose of a compound, which its trade name is multi-hands. I think it's dimegamine. And it has, it's essentially a gadolinium bound with salt, but it has a higher relaxivity than the other agents that we use, so we're able to use less of it. So if we have a patient with renal insufficiency, we go ahead and perform a single dose gadolinium administration with the multi-hands, and we've demonstrated that we've been able to get quite good image quality, both for delayed contrast enhanced imaging and then other, magnetic resonance angiography or other imaging that we're doing. Yeah.
I wonder if you can share with us what you think about patient-specific three-dimensional models. So I reviewed a number of grants and papers, seen several reports from Hopkins, Duke, MIT, Harvard, Minnesota, I believe, and some number of other groups, which basically claim that pretty soon we will be able, by using advanced MRI imaging, to reconstruct three-dimensional structure of myocardium, including infarction scars in other areas of damage fibrosis, and basically predict, based on that, areas of likely origin of arrhythmias and then placement of defibrillation leads, which can be optimized with respect to scarring in this particular patient. So how far do you think it's...
As far as three-dimensional.
Right.
So right now there are three-dimensional sequences that you can use for delayed contrast enhanced imaging. They are balanced gradient recalled echo sequences, similar to actually what the same type of sequence that's used for the cine imaging, but in a three-dimensional fashion. The only problem with those is that you end up with decreased resolution. So the resolution isn't quite as good because the goal then is to acquire all of this in a single breath hold. So, the patient has to hold their breath for that entire time that you're, covering the, so once you start imaging in the X, Y, and then Z axis to get 3 dimensions, the patient has to hold their breath longer, and so the resolution is poorer. Now, there are some techniques, respiratory gated sequences that people have coupled to true FISP sequences for coronary imaging. And I think it would be possible, and some people may be doing this, I haven't seen anything that currently couples it, but you could take navigators and couple it to a delayed contrast enhanced sequence, and then go ahead and basically have a longer period of time to acquire your data, so you could also have higher resolution. So I think that would be something that, if we wanted to talk to one of the physicists in the East Building, might be worth exploring. There's also a cine sequence that on one of the scanners, we can actually acquire three-dimensional cine. However, the breath hold is ungodly long. We tried, one of our fellows who has done a lot of swimming and diving actually tried doing this and held his breath for like 2 minutes, and we were able to get some pretty decent cine imaging. The only problem with that, you'd like to be able to, let's say, acquire it just once in, let's say, a transverse fashion, and then be able to slice it up into short axis and long axis images. And currently you can't do that, so there's difficulty in post-processing it. So I think that they are moving towards, we will have some type of three-dimensional assessment for function, and also three-dimensional assessment for delayed contrast enhanced imaging. Now CT, you have essentially a three-dimensional assessment of function. The delayed contrast enhanced imaging with CT is not quite as good. You can do it, but you don't have anything to dull the normal myocardium, so the contrast isn't as good, for one. And then secondly, you're also giving the patient additional radiation. If you go back, you've performed your gated sequence for your cardiac coronaries and your function, then you go back again and do delayed, you're giving them the additional radiation dose.
So what is the clinical indication for delayed contrast gadolinium? Who's getting it?
Who orders it?
Everybody who had a myocardial infarction, or?
No, it's essentially surgeons who are planning to take, I should say two groups of people. Patients who've had myocardial infarction, and the surgeons would like to know prior to taking them to the operating room whether or not they'll have wall motion recovery with reperfusion. In other words, so you have somebody who's sick, they have emphysema, they have diabetes, and their risk of going to the OR, they're a high surgical risk. In other words, they may end up dying, they may end up being intubated and have a prolonged intubation. And the surgeon wants to know, if I take this patient to the operating room, am I really going to improve this patient's cardiac function, or am I just going to perform the bypass and it's just, the EF's going to stay the same, the patient's just going to be in the unit for months. Or am I going to be able to perform this and the wall motion will recover? So that's the principal group of patients. But then also patients who have cardiomyopathy of unknown etiology. So patients who have a dilated cardiomyopathy or hypertrophic cardiomyopathy, and the cardiologists are trying to figure out how can we treat this patient. So, in some patients, is it a myocarditis? Is it something that's going to be self-limited and resolved? Is it something that is infiltrative? Often these patients who have chronic infiltrative cardiomyopathies that they don't think are ischemic, they want to know, does this look like sarcoid? Is this acute sarcoid or chronic sarcoid? With chronic sarcoid, you get thinning, very similar to a myocardial infarction, but the delayed contrast enhancement picture is different. So you can give them some guidance as to what their patient might have, and then sometimes you can give them guidance if they're performing a biopsy. They're usually right heart biopsies, endomyocardial biopsies, and so they're often very low yield. And if you're able to say, look, there's some enhancement in this region, it's involving the right ventricle, then you can give them some guidance as to where they could actually perform the biopsy. So those, I would say, would be the three clinical indications.
Any other questions? Okay, thank you so much.
You're welcome.
In radiology, and what we're trying to do here is, which is mostly take. I appeared it was one of the best physicians, and the involvement in the profession has been on many. In terms of her education, she got her MD from Duke University, and then continued the Chapel,
My internship.
the rival for a fellowship and remained at the Mallinckrodt Institute. He came from Case Western Reserve University. We're really that part of my work has to do with the electrocardiographic imaging work at the Chem building, and without her, we would have been lost.
Saying about me, and I do apologize for the delay. I'm going to be talking about delayed contrast enhanced cardiac MRI. So you're looking at regions of the myocardium, which can and Kim, now at Duke University, cover you would get after revascularization. So there are several patterns in a vascular way. The infarction, you have this normal myocardium patients who have transmural enhancement. To go ahead and do this type of region of myocardium, which on delayed enhancement gadolinium-based molecules. So these are some cartoons that show this. This is from a book by gadolinium molecules, and the gadolinium then washes out in the delayed. But you can use delayed contrast enhanced imaging for other pathologies as well. Essentially, in cardiomyopathy, you see the thick myocardium, the thick septum as well. Patients who have myocarditis have it's usually obtained with cine sequences that you see Fiesta, but the cine sequence shows you that so you have a hypokinetic posterior septal wall, and the area of and you can see the corresponding enhanced region on the delayed aneurysm. The patient wouldn't have much left ventricle available. You can see that there's an area of hypoperfusion here in the infraceptum, and you can see not only subepicardial enhancement, but also that striatal enhancement that the etiology originally may have. You can see that in this particular individual, there was no delayed contrast enhancement. Have this because it's indicative that during surgery, scarring showed an area of hypokinesis, segmental hypokinesis in the anterior wall. And so they were able to calculate that information to provide some indication. This is work done by Young in his lab, where you have a very low voltage, low MRI, to provide a visual depiction of the uranium to patients who have GFRs as low as 30. In a transverse fashion, and then be able to slice it up into assessment for function and also three-dimensional assessment for delayed contrast.
Any other questions?